lectures. So, all right. So, I thought I'd put infectious diseases. I felt needed a second look. ID is part of a review. I think it's in April. You'll get an ID lecture as well, different from this one. But ID is very challenging, but it's a great way to nail some questions because it's all. I call them it's if you're in a baseball, these are the fastballs. They're just going to come at you at 95 miles an hour and say, can you hit this? So they just say, do you know it or do you not know it? So I thought it would be good for you to get a perspective from me and then another faculty member also to give you an ID lecture because it's worth 2 lectures. It's that, and nothing against cardiology and pulmonary and endocrine. Those are important too. But I think you guys can handle those, and they tend to ask situations that you've gone over. Whereas ID, sometimes they do get a little esoteric, or they just are. There's so many drugs that sometimes you've gotten lost as far as what drug should be treated because there's every ID physician has a different take on what they like and what they don't like. For all those reasons, that's why we're giving it a little bit extra love in the board review session. All right, so don't lose easy stuff. Diabetic foot ulcer is still good old Zosyn. Probably the only time you'll answer Zosyn is going to be diabetic foot ulcer on your test. There may be another situation, but in general, I'm going to look at piperacillin tazobactam as I'm answering with too big a gun for the situation. But what if they don't give you piperacillin tazobactam for diabetic foot ulcer? They love going to timentin, ticarcillin covalinic acid, which is not big in the South, but it's used a lot in the Northeast and the Midwest. Again, these are all regional tendencies, probably driven by availability of drug and how well the drug is pushed in certain areas. But I just want you to be aware so you don't panic if you don't see piperacillin tazobactam on your test. That you don't go, oh my God, I have no idea what to do next. All right, what if you have a cellulitis and they're not diabetic? First line is IV cefazolin. First generation cephalosporin. I know you guys hate using that drug, but that drug is even being used more and more so for MSSA, as you guys know, over vancomycin. Over nafcillin itself, or IV Unison. Ampicillin sulbactam is fine for regular cellulitis, or IV nafcillin, which brings you oxacillin. All those are acceptable choices for a cellulitis that does not look like, a diabetic foot ulcer. And then if they give you erysipelas, which is almost always group A strep, you should use ampicillin sulbactam as your drug of choice because that shows that group A strep is a likely pathogen and that ampicillin sulbactam is really targeting streptococcus. All right, erysipeloid we already went through. The nice thing about erysipeloid is you can use every common drug, but so you should not be using big guns. And whenever you can use other drugs than a fluoroquinolone, the answer is don't choose a fluoroquinolone. So you're going to want to go with trimethoprim sulfamethoxazole, Septra, or clindamycin more than a fluoroquinolone, or even go with oral pen VK with Clinda or Septra for erysipelotrix rhizopathia, erysipeloid. Streaking erythema, almost always strep. So here, ampicillin sulbactam, and if that choice is linked to clindamycin, that's okay, because the clindamycin helps bind the toxin of a very aggressive strep infection. What if they start talking about anesthesia to light touch? In that case, always think necrotizing fasciitis. Especially in the perineum, it's Fournier's. You need to be on an operating table. That's number one. What are you on? You're on an operating table. The second thing is obviously what drugs do you choose to go with it? You could use anything directed. If you have a bug, put the direction toward the bug. If you don't have a bug and they're a diabetic, then it's okay to use piperacillin, tazobactam, and then you probably would still also want to use a drug like clindamycin because that also inhibits, if you remember back from your old days, the 50S bacterial ribosomes and thus stop protein synthesis dead in its tracks. How about some other things? If you have a human bite, So human bite, Eikenella and Kingella. All right, those are the two most common bugs. Eikenella corrodens or Kingella kingi. And the drug of choice is ceftriaxone. And you knew that because when you were in 9th grade or 10th grade, you learned about ceftriaxone for the HASEC infections of endocarditis, of which E is Eikenella and K is Kingella. How about if a dog bites you? If a dog bites you, the most common organism from a dog or a cat bite is Pasteurella multicida, which, as you know, can be treated with ampicillin sulbactam. If you have no spleen, then you're at risk of DF2, which is dog dysgonic fermenter 2, which has now been changed to Capnocytophagia canemorsis. And Capnocytophagia canemorsis, actually should be canemorsis, is treated with penicillin or ampicillin sulbactam. But you need to identify, if you have no spleen, you're thinking Capnocytophagia canemorsis, and it's a really aggressive sepsis syndrome. You still can get an aggressive sepsis syndrome if you have a spleen. And if you have a spleen and you have a dog bite, then I think of Pasteurella multicida. So notice how sometimes you have to adjust to the information you're given on the question. Hot tubs, whirlpools, swimming pools. They like you to know Pseudomonas. Saunas, there's a new organism for sauna, not new, but a different organism for sauna, actually called sauna taker's lung. People who like to take a sauna are called sauna takers. What a strange name. But the organism then is Aureobasidium. If you're like, meh, I'm missing that one, Lezama. All right, whatever. But the organism is Aureobasidium, A-U-R-E-O, Basidium, B-A-S-I-D-I-U-M, for sauna. So sauna takes on a little different than the hot tub, whirlpool, and swimming pool. You still at risk of Pseudomonas with a sauna, but this other organism tends to have predominance. I have no idea why. All right, we already kind of went over erysipeloid and what that is. So, erythema chronica migrans with Lyme disease, empiric treatment. You see the rash. You go doxycycline, 21 days. Thank you very much. I'm not ordering any other tests. It's that, bam. You drop the mic. If you start seeing advancing carditis, or you start seeing meningoencephalitis, facial palsies, then you want to amp it up to ceftriaxone. Remember, if your patient is what if they're a land surveyor or a lifeguard, and Harold Paul's like, I need you to take Doxy. And the person says, I ain't missing a paycheck, Harold Paul. And Harold Paul goes, that's Dr. Paul to you. I didn't go to school for 8 years to be called, Harold Paul. I want to be called Dr. Paul. All right, anyway, in that case, then you can choose ampicillin, oral ampicillin, instead of Doxy as first line for any heavy sun exposure people. Early Bell's palsy you can treat with Doxy, but Bell's palsy with any other neurological sign equals ceftriaxone. All right, how about bullous hemorrhagic lesions? This is due to Vibrio vulnificus or Vibrio parahemolyticus. Look out for liver disease patients that eat raw seafood or oysters or go in the seawater. They're not allowed to do so. Anybody who has advanced liver disease, the only thing they're allowed to do is go in a bathtub with bleach. I think that's what I tell them. So I exaggerate so that they get the point. May not put my little foot in the water. I had one patient say, can I at least touch the water with the foot? I went, no. So I don't want you to even be able to breathe salt water. That's how far away I want you from salt water. And then there's a risk in fresh water as well. That's why I'm saying, their own bathtub with bleach, they can go in there. If they eat the stuff, the biggest risk is parahemolyticus. They have asked the difference between parahemolyticus and vulnificus before. The way I remember it is PO is oral, POP parahemolyticus. And the other one is vulnificus, is mostly skin. That's the way I remember the two. First line treatment, of course, doxycycline. They may ask you if they're in severe ICU state for you to add cefepime, 4th generation cephalosporin, to the doxycycline. But what is going to be the complete answer? What if B says doxycycline and cefepime. Watch out for E that might say doxycycline, cefepime, and a surgical consultation, because Vibrio is very aggressive and likes to cause fasciitis. So you want to get a surgeon involved in these cases early if the patient is looking extremely severe. If it's just really mild disease at the beginning, you caught it real early, then you don't need to involve a surgeon. You can just use doxycycline. Yes, Phil?
When you add the
Cefepime for severe cases. So I would say ICU. If you're headed to the ICU, a good rule to remember is 2 drugs to the ICU, whether it's pneumonia, anything, whether it's Legionella, whether it's Vibrio sepsis. Always want to think 2 drugs. And the 2 drugs here, doxycycline and cefepime. And then I added surgical consultation also should be done. All right. Nodular lymphangiitis. This is where you get a ulcer in maybe a little bit like this. So I cut myself, I don't know, doing something with the yard this weekend. And so let's say I get an ulcer on this tonight, and in 2 or 3 days I get similar ulcers going up my arm. I hope not. But if so, that's called nodular lymphangiitis. And also it's known as something called a sporotrichoid pattern, which means it's like sporotrichosis. Doesn't mean it is sporotrichosis. It means it's like sporotrichosis. So if you're an excellent resident, like say Stephanie D'Souza, you might be Stephanie D'Souza. Or you might be Savan Shah, or you might be, Danielle Jordan Pearson, Danielle Pearson Jordan. I always forget which one. I think Pearson is the new one. So Janelle Jordan is the old one. So, you'd be D'Souzoid, is what you would be. So you're might not be D'Souza, but you're like D'Souza. So sporotrichoid means it doesn't always have to be sporotrichosis. It might be something that's like sporotrichosis. And here are the organisms that like to do it. The movie itself, Sporothrix shanki. Remember, that's a fungus, and you treat with itraconazole. Nocardia brasiliensis, like any nocardia, gets treated with trimethoprim, sulfamethoxazole. The second line treatment, remember you always have to learn second line, of nocardia is doxycycline, which follows a rule. If it's weird and I have no freaking clue, I'm answering doxycycline. All right? So, if somebody went, I'd be like, I'm giving that guy doxycycline. So, I have no idea what the hell goes, but doxy might cure it. Tularemia can treat with doxycycline, first line, or fluoroquinolone, second line. Remember, tularemia can also cause pneumonia, which is different than anthrax. Anthrax causes hemorrhagic mediastinitis, not pneumonia. So anthrax, hemorrhagic mediastinitis, meaning you have a widened mediastinum and you're bleeding. You have a hemorrhagic mediastinitis, as opposed to tularemia, which causes pulmonary infiltrates and a very aggressive pneumonia. The ulcers of tularemia are extremely painful as well, as opposed to a lot of other conditions that have painless ulcers. Always think of tularemia as very painful ulcers. Leishmaniasis, which we just had a case presented at the VA that was a TGH case. Who the hell presented that? It was a senior, wasn't it? Who presented the leishmaniasis case?
Sam.
Was Sam? All right, so that's right. It might have been Sam. So Sam's not quite a third year. So leishmaniasis, treat with IV sodium stipogluconate. If you're like, what the hell? So second line, if you can't get sodium stipogluconate, is going to be thiabendazole, mebendazole. That you can also treat leishmaniasis. Again, usually Middle East, but can be like Sam's patient came out of South America. So there is leishmaniasis in Central and South America. It tends to be a very aggressive ulcer. It was Crystal. You presented. It was you. I was like, I thought it was a third year. Crystal presented the case.
That was morning report.
That was morning report at the VA. But the case was from here, right?
Yeah.
Yeah, the guy was in with Colombia, right?
Oh, no, he was Haitian, and then he traveled to Mexico.
Mexico, all right. Mexico. All right, anyway. So these are the drugs for leishmaniasis, and that can also cause a sporotrichoid. We already talked about erythrasma. A Woods lamp will fluoresce coral red because of the bacterial byproducts. The treatment of erythrasma is erythromycin. So, or any macrolide will work. Guess what second line? Doxy. So, like I said, usually doxy is your savior. But it's not first line. So if you answer first line erythrasma doxy, you're missing it. It's a macrolide. Tinea is a dermatophyte. It responds to terbinafine. It does not respond to nystatin. Nystatin is used for Candida. Very different. Candida, pseudohyphae. Tinea, real hyphae. Tinea does not have satellite lesions like candidiasis does. So this is basic. I don't know, I'm sorry if you're like, are you kidding me? But a lot of people struggle with this because they get all into sepsis. They forget how to treat sniffles. So I'm making sure you don't forget how to treat sniffles, which to me, this is like sniffles. Candidiasis, satellite lesions, tinea, no satellite lesions, tinea, terbinafine, TT, candidiasis, nystatin. So the most common tinea in adults is trichophyton, as opposed to kids, which I believe is still microsporin. But you know, Dr. Mayberg can teach his own pediatric board review course. So, but trichophyton, rubrum, or mentagrophytes, to be specific on the species. Are they going to ask you the species? No, thank God. They're only going to want you to know that trichophyton is the most common genus for tinea and not microsporin. Lyme disease, we kind of already went over. Let's talk about the other tick bite that comes with Ixodes scapularis, also known as Ixodes damini, because it's damn, it can cause 3 drugs, or 3 diseases. Ehrlichia. For the boards, you don't have to know the monocytic or the neutrophilic variant of Ehrlichia. Thank God. Just for your boards, Ehrlichia is equivalent to anaplasmosis. Anaplasmosis is equivalent to Ehrlichia. Finkel is Einhorn. Einhorn is Finkel. For those who watch Ace Ventura. So they're the same thing for your tests. So somebody's watched Ace Ventura. Thank God. So you guys don't watch any of the classic movies, and you're missing out on culture and the sense of humor. Splenomegaly, hepatitis, thrombocytopenia, white blood cell inclusions, treat with doxy for ehrlichiosis, also called anaplasmosis. Babesiosis, hemolytic anemia with red blood cell inclusions. Sometimes these organisms can take what's called an intracytoplasmic tetrad form. The intracytoplasmic tetrad form is called the Maltese cross. They're not likely to put Maltese cross on your test because they know that'll help you get the question right. They're more likely to put the harder description, which is the intracytoplasmic tetrad form, in the red blood cell, not the white blood cell. Notice, Ehrlichia, white blood cell inclusion. Babesiosis, red blood cell inclusion. Very big difference. Also, big difference in treatment. Azithromycin and atovaquone is how you treat babesiosis. I call it the AA battery, all right? Because B is babesiosis, B battery, babesiosis, AA, the treatment, AA, atovaquone, azithromycin. The other treatment is quinine and clinda, which you've seen together in treatment of other diseases, like it's one of the regimens that can be used for malaria, for instance. All right, endocarditis. So MSSA, they're still going to go with nafcillin on your test. They're not going to go with cefazolin. But just know that in real life, we are using a lot of cefazolin to treat MSSA. But they'll go with nafcillin, and they usually will go for longer than 2 weeks. I think here I meant right-sided endocarditis, especially if it's a jailed person. You can actually even go for a short course. The aminoglycoside in general is until blood culture's clear. That's probably your best rule of thumb as to how long to keep an aminoglycoside around in treating endocarditis. They like asking questions which are what I say are gamer questions. They're not zebra questions, they're gamer questions. How long, I start somebody on nafcillin and gent, they have positive blood cultures, they have endocarditis. How long do I continue the aminoglycoside for? The better gamer answer is until the blood culture is clear, not necessarily 2 weeks. If IV drug abuser, you know you start with MRSA coverage, so vancomycin. If they have a prosthetic valve, then you have to add something else. What else do you have to add? Rifampin, right? So rifampin has to be there if they have a prosthetic valve and they have endocarditis. If they don't have a prosthetic valve, you don't have to use rifampin. If the patient turns out to have MSSA, even if they're getting better and doing jumping jacks in the room and push-ups, you go, I'm sorry, I'm taking you off the vancomycin and I'm switching you to nafcillin because your blood cultures came back positive for MSSA. So you get off an MRSA treatment regimen if the blood cultures show that it's MSSA, even if the patient is dramatically improving, because you want to tailor your treatment to what the blood culture is. Hasek, we already talked about ceftriaxone, and watch out for Q fever. Q fever likes to cause endocarditis. Coxiella burnetii is a big maker of endocarditis, especially in Europe, but also seen here. And Coxiella burnetii, also known for liver failure. So if you have liver failure and endocarditis and you're culture negative, the answer is Coxiella burnetii. What's the drug of choice? It's strange, right? Blah, blah, blah. Doxy, right? Doxycycline. Very good. Mycoplasma. Look at all the fun stuff mycoplasma causes. It can cause a headache from aseptic meningitis, bullous meningitis, transverse myelitis, erythema multiforme, cold agglutinin. This is a playa, all right? Mycoplasma is one hell of a playa. So any of these given, you're ready to answer mycoplasma pneumonia, of which you know a macrolide or doxycycline is your first line agent. Chlamydia psittaci is always going to be somebody who has a bird, a parrot, parakeet, or whatever the hell those birds. I hate birds. So I like seeing them fly around outside people's homes. And then chlamydia, also known as now chlamydiophilia pneumoniae. The key is not only sore throat but hoarseness. So if you have a bacterial, they'll tell you you suspect an atypical bacterial infection. Marked hoarseness and sore throat is noticed in the patient. Go with chlamydiophilia pneumoniae as your organism, and that also is treated with azithromycin and doxycycline. Emphysematous pyelonephritis, most common cause, E. coli, and you see it in diabetics. First line is still IV fluoroquinolone. Now, what you need to know is you got to do imaging. So if somebody has a very aggressive pyelonephritis and they're a diabetic, do imaging. Get a CT scan. You don't even have to do a contrasted study. Get a non-contrasted CT. You could do a sono. It's not as easily seen in sono. I usually prefer non-contrasted CT. So you can see whether somebody has emphysematous changes in their kidney. If they do, you need to involve a surgeon in the case. Even though they may actually even go to an IR for drainage if it looks more like an abscess, you still want to involve a general surgeon on the case. And what's the most common cause of emphysematous cholecystitis? E. coli, just like emphysematous pyelonephritis. Same thing. Obviously, you involve a surgeon very early in emphysematous cholecystitis. So E. coli is the winner in emphysematous pyelonephritis and emphysematous cholecystitis as far as number one pathogen. Never ever use Scepter for a patient that has true pyelonephritis. Don't use nitrofurantoin either. Scepter and nitrofurantoin are only for lower urinary tract infections. Anything that is at the level of the kidney should be treated with a fluoroquinolone. This is one time you can use a fluoroquinolone without somebody like jumping out from the ceiling tiles going, "How dare you?" All right. Do you know how many antibiotics you're resisting now? So I always got, I told my, where's Shreya? I told Shreya, watch how quickly I get called by an ID doctor. I'm going to enter an order for Levaquin. Blah, 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 blah. It's like 3 minutes later, she's being paged. Can you take that patient off of Levaquin? They never call me because they fear me, I guess. So they always call my resident. Can you get that antibiotic off? So, all right. Male, 7 days. You know that, minimum treatment. And you should work up for kidney stones or urological abnormality. And then the cutoff for nitrofurantoin is a creatinine clearance of 50. So watch out. I know you like going to nitrofurantoin, especially in females, young females, pregnant patients, but if they have chronic kidney disease, you can't use nitrofurantoin. If their creatinine clearance is under 50, you can't do it. Diarrhea, a couple words. Most common traveler's type is enterotoxigenic E. coli. That's easy to remember because T for traveler. Most common bacterial U.S. Campylobacter. I know you're like, that's a disease of the Orient. That's a disease in South America. Guess what? It's a disease in South Tampa. So Campylobacter is number one bacterial cause. In asplenic patients, it's Salmonella. So if you're like, well, what do I answer if somebody has a bacterial infection and they have no spleen? They told you they have no spleen for a reason. So you would answer Salmonella. So any information given to you on the test, you have to use in that question answer reconciliation tip. And then reactive arthritis does not come from E. coli. Salmonella, Shigella, Yersinia, and Campylobacter. They're, as I call it, they're like the four dirty beetles. if you will. The Beatles were 4 people. You may have heard of them. You know, Paul McCartney is one of them still alive. So, Salmonella, Shigella, Yersinia, Campylobacter. And then the treatment of these organisms, of these bugs, is a fluoroquinolone. But what if they don't have a fluoroquinolone as a choice on the test? The next answer would be ceftriaxone. Ceftriaxone. Just like, and the way to remember it is Yersinia's first-line treatment is ceftriaxone. So the other ones also respond to ceftriaxone. Meningitis. Always start broad, vanc and ceftriaxone, and then add IV ampicillin if the patient's pregnant, above 65, history of leukemia, lymphoma, or is a transplant patient. Then you add ampicillin. Then, once they give you the CSF result, you must tailor your antibiotics. Even though they're getting better, you can't say, well, they're getting better, I'm just going to leave them on everything. They give you the result of the CSF for a reason. They want you to show off your knowledge. So if it's a gram-negative diplococci, it's Neisseria, and you're dropping everything except ceftriaxone. If it's a gram-positive diplococci, which I can't spell diplococci, it's strep pneumo, and then you drop ampicillin, but continue vanc and ceftriaxone till the oxacillin disc diffusion test result returns. If it's susceptible on there, then you can stop vancomycin. Very important that you follow that rule. And then if it's a gram-positive rod, it's Listeria. And in which case, ampicillin's the only drug you need if it's Listeria. Now, what if you have a severe penicillin allergy? You need to know the second-line treatment of Listeria, and that's trimethoprim sulfamethoxazole. So Septra is second-line treatment of Listeria, for Listeria. Because you won't have time to desensitize the patient. That patient is going to be dead. So if you choose desensitization on the boards, you're going to be desensitizing a corpse at the funeral home. That's what you're going to be doing. Because there's no time to waste. How do you desensitize a penicillin patient? You give them low doses and you build them up. You can't do that when they have meningitis. They need the most powerful dose now. They needed it yesterday, but they need it now. And if you have a severe penicillin allergy, you go to Septra and you bang them with Septra at the highest dose that is acceptable for meningitis in that case. All right, now that's different than if you have syphilis and you're pregnant. If you have syphilis and you're not pregnant, it's not like the spirochetes are going, die, thou die. All right, so they're very slow. Go ahead and die if you wish. We're around. So you have time to desensitize the syphilis patient that has a penicillin severe allergy. You don't have that time in meningitis. And they know that you might get confused, and they like to see how you respond on the test when they give you severe penicillin allergy. SBP. Don't miss SBP. I mean, it's like if you go into, it's like I should come up with 10 things you definitely learn going through the VA medicine wards. One should be treatment of SBP. So many ascites patients we have. Good Lord. All right, first line is cefotaxamine or ceftriaxone, not fluoroquinolone. Fluoroquinolone is second line in SBP treatment. And then lifelong prophylaxis, it's one episode of SBP and you've got a lifetime membership to the SBP prophylaxis club. Now, if you get a transplant, you likely can come off of that eventually, but that's not going to be on your boards. So first line for SBP prophylaxis is trimethoprim sulfamethoxazole, twice weekly. Watch out. They'll put once weekly, twice weekly, and you'll be like, oh crap. That's where you didn't follow my tip to study to the nth detail. So twice weekly Septra, are we in France? Septra, or fluoroquinolone once weekly. A second line agent, not first line. Everybody cool with that? I mean, this is where they get you. They get you with the zebras, some zebras here and there, but they really poke your eyes out with just how well do you know all the specific ID crap. All right, parotid head and neck, oral dicloxacillin is the first line, oral dicloxacillin or IV oxacillin, if you have to admit them, is the first line treatment of an acute parotid gland infection. Why? Because 98% plus are methicillin sensitive Staph aureus. So this is where you answer augmentin, you miss the question. You answer fluoroquinolone, you miss the question. You answer Clinda, you miss the question. You answer doxy, you miss the question. They want you to choose dicloxacillin because that's the oral anti-staphylococcal beta-lactam agent to the stars. Then watch out for Lemierre syndrome. This is Dr. John Green's favorite diagnosis, by the way. If you want to make him really excited, go, Dr. Green, I've been reading about Lemierre syndrome. He'll be like, yes, tell me more. He'll probably buy you lunch. So anyway, Fusobacterium necrophorum is the most common cause, although it can be caused by even anaerobic strep. But for your boards, you go with Fusobacterium necrophorum. Remember, it starts in the submental space, and it likes to then go down the internal jugular vein and cause an internal jugular vein thrombophlebitis, followed by septic pulmonary emboli. The treatment is IV beta-lactam and an aminoglycoside. That's the treatment. HIV medicine. So what do I study for HIV medicine? Efavirenz, vivid nightmares, CNS. Even though we say contraindicated in pregnancy has been showing up as now okay for pregnancy, I would say on your boards, if that's the only drug to avoid, then choose efavirenz. But just know that it's now becoming, it's probably okay in pregnancy. Used to say, no way, Jose. But it is the one that definitely causes the most CNS vivid nightmares. So 2 drugs you need to know for nightmares on the boards. One is efavirenz in HIV patients. What's the other one? Beta blockers is exactly correct. Well done. So see, Disuzan-like, Disuzoid. So we coined a new term. Protease inhibitors. Lipodystrophy, which is that buffalo hump, and that big belly, which looks like ascites but isn't. If you put an ultrasound sono, there's not even a trace of fluid. It's just fat deposition centrally. This can be caused by HIV itself, but it's worsened if using a protease inhibitor. But please, if they put a question and they give you lipodystrophy and they're not on a protease inhibitor and they say, what is the cause? The answer is HIV itself. Lipodystrophy, all right, already talked about that a little bit. You get primary hypogonadism with lipodystrophy. And then the other one to know for your boards is abacavir. It causes an acute hypersensitivity syndrome, very similar to what other 2 drugs? Allopurinol and Dilantin, phenytoin. So allopurinol, Dilantin, phenytoin, and abacavir are the 3 drugs to know for hypersensitivity syndrome. Remember that abacavir is a guanosine analog nucleosidase reverse transcriptase inhibitor. Because remember the tip I told you, maybe they don't ask you the drug. They say a patient with HIV develops an acute hypersensitivity syndrome. You're going, sweet, abacavir, I'm about to cash in. You're thinking of cha-ching. You get down to the choices. There's no abacavir. There's a bunch of drug classes. You'll be ready, because I told you that tip. And even if they say guanosine, nucleoside reverse transcriptase inhibitor. This is probably the only one that you have to even know this detail, because the other ones you don't really need to know. But you do need to know nucleoside reverse transcriptase inhibitor as opposed to something like delaviridine, which is a non-nucleoside reverse transcriptase inhibitor. All right, dengue fever. The breakbone fever description, hemorrhagic variant if you've been exposed before, the Aedes mosquito transmits. And then in malaria, I want you to know that the cerebral variant is caused by falciparum. The high parasitemia is caused by falciparum. So, if I have cerebral malaria, my choices are going to be, how I'm going to treat. I'm going to treat with quinine and doxy. I'm going to add pentaxaphylline because it's cerebral malaria. And believe it or not, there's data for using Trental, which is old drug used for peripheral vascular disease. There's data in using this drug for treating cerebral malaria. And I'm going to add red blood cell exchange transfusions for cerebral malaria and or any parasitemia that is above 5 to 15% in that range. I'm going to add red blood cell exchange transfusions to the treatment. So this one's kind of it's a heavy duty one. Q fever we talked about. Tropical sprue. If you go to the Caribbean or sub-Saharan Africa or India, Malaysia, those are the areas they like to give you. And you come back with something that looks like celiac sprue. But celiac testing is negative. The biopsy is very similar to celiac sprue. You have no serology. You decide your answer is tropical sprue. The treatment is high-dose tetracycline and folinic acid for 4 to 6 months. So it's a long treatment. Let me review with you some of the long treatment ID ones. One of them is tropical sprue, 4 to 6 months, tetracycline and high-dose folinic acid. The literature article for which this is tagged to, 1957. That's how long ago. For fun, I looked up, what is the source for this question? 1950s, amazing. They're still being asked on the boards almost 80 years later, 70 years later. Whipple disease, which is the only malabsorption that causes hyperpigmentation. So that's a gift. If they give you somebody with malabsorption and hyperpigmentation, bam, you got Whipple's disease. It can also cause endocarditis. It can cause advancing CNS, almost like a pseudodementia. Really, you should write pseudodementia there. But you treat with trimethoprim, sulfamethoxazole, for 12 to 18 months when you're treating Whipple's. 12 to 18 months. We've had a few cases of Whipple's at USF in the last 5 years. A couple that have been presented at Morning Report, I think one here. PAS-laden macrophages on biopsy tissue is what you see. Second line for Whipple's, if you can't take Septra, say you have a severe allergy, is minocycline, which is like doxycycline, is minocycline. All right, nocardia and actinomycosis. Nocardia, Septra for 3 to 6 months is a treatment. It can cause a brain abscess for which you may need IV amikacin for a few weeks before disseminated subcutaneous nodules in the skin, cavitary lung disease, and it's even AFB positive. It says partial, but it'll be AFB positive. It's a matter of your lab telling you how positive the AFB is. So, but if you look for most labs, they'll just read it positive. And it's up to you to pick up the phone and go, was that a high, strong positive or a partial positive? And again, the way you distinguish it from TB is there's a gram stain with nocardia. It tends to be it's a gram-positive coccobacillus form. That's nocardia. Actinomycosis, also known as the fistula former, classic with intrauterine devices, but you can get fistulous disease anywhere in the body. Treatment, penicillin, is first-line treatment for actinomycosis, as opposed to Septra for nocardia, and that's where they came up with the mnemonic SNAP, and SNAP is Septra for nocardia, and actinomycosis is treated with penicillin. And they came up with a mnemonic called SNAP. I don't know, has anybody heard of SNAP? So, no? All right. Anyone heard of the band SNAP? They got some good stuff. In the 90s, I was at UF dancing, not twerking, dancing to SNAP. So, Rhythm is a Dancer, I believe, is Snaps.
Oh.
Yeah. I'm almost positive Snap sings Rhythm is a Dancer. You know, in the lyrics it says, I'm serious as cancer. Rhythm is a dancer. So I'm almost positive that's in the lyrics. So, all right. Anyway, all right. We'll see if we can bring up YouTube during one of the breaks. All right. Travel medicine. Yellow fever, remember, is a live attenuated vaccine. So you got to watch out for egg allergies and yellow fever like you do in flu. So that's a little tip that I know they love to ask on the boards. Hep A. Really, for Hep A, all you need is one immunization. It covers 95% plus. And that's 2 weeks before you leave, get a Hep A vaccine to a culprit area. If you want to be greater than 95%, get a Hep A vaccine 6 months prior and get a booster 2 weeks before you leave. But the recommendation I think you should go for on your boards is a Hep A vaccination 2 weeks before you leave. Typhoid fever. Remember, typhoid fever likes to cause Fagey sign. Fagey sign is where you have a fever of 103 and you have a pulse of 50. So it's called a it's a pulse temperature dissociation. The classic disease was actually yellow fever, when it was noted originally, but it's actually seen more in typhoid fever. And the rose spots are those classic. That's a classic sign to see. Rose spots usually coming out when they have fever. Is to see with typhoid fever. And there are oral or even inactivated vaccines available, but not a live attenuated. So no live oral or inactivated vaccines for typhoid. And then meningococcal, still for your boards. The standard meningococcal covers ACY and W135. There now is a new meningococcal B vaccine, but it's a standalone B vaccine. That's not going to be asked on the boards yet, but they do want you to know type B is the most common meningitis that you'll get in college dormitories, the military, etc. That's the most common, even though these other four can still happen. And now there is a separate type B meningococcal vaccine out there. The pediatricians know it very well. All right, I kind of went over diarrhea plenty. Leptospirosis. No way you want to miss leptospirosis. Remember we just had where was it at? Was this week's board review? Or yeah, ID board review last week. We had a question of somebody who went to Hawaii and swam in the lakes and ponds of Hawaii and came back with renal failure and jaundice, and they had leptospirosis, of which the treatment is ceftriaxone, first line. Second line is doxycycline for leptospirosis. That's why I've been focusing a lot in this talk on first line treatment, second line treatment. So you start practicing, and this lecture you have for eternity to look over. We had somebody, when Survivor first came out, there were 5 kids in Hillsborough County who did this and got leptospirosis. So you don't have to go to Hawaii to get the leptospirosis. You can just go in the boondocks of Hillsborough County and you can get leptospirosis. So you don't, if you're like, I need to go to Hawaii to try to partake in this. No, you just go to, the boondocks, go to Temple Terrace, jump in one of the woods of Temple Terrace, not far from the VA, and then come to the VA all jaundiced and in renal failure, and we'll take care of you. We'll admit you humanitarian, and then we'll transfer you somewhere. You can cap a team out. Isn't that cool? You're like, that's not cool. Pneumonia. This is like the sniffles. I don't want you to admit, you get leptospirosis right, you get typhoid fever right, you get the vaccine for yellow fever, then they ask you a pneumonia question and you miss it. Let's not do that. All right? So, outpatient first line, macrolide, azithromycin, first line for pneumonia. Second line, doxycycline. All right? Not moxifloxacin. We don't want to be using fluoroquinolones unless we have to. That's like third or fourth line. So there's doxycycline. Do not use Septra or PEMVK or amoxicillin for pneumonia. All right? Unless it's like pneumocystis cerevisiae. All right, well, that's different. Or nocardia pneumonia, that's different. I'm talking about strep pneumo. Augmentin, especially if it's Moraxella catarrhalis. They love MCAT, Moraxella catarrhalis, lovingly named after the horrific test that we all have to take. Moraxella catarrhalis is an augmentin maker. The answer is always augmentin. You can never give just amoxicillin. Moraxella catarrhalis loves beta-lactamase activity, so it has to always get amoxicillin clavulanic acid. All right, GU is pretty straightforward. What time do we have? Because I want to get to 10. Are we right at 10? All right, I already went over babesiosis. I like this slide. I have a couple more slides and then we'll break for about 10 minutes. I think I can make up the time in allergy and dermatology. Notice, I love this category because this helps you. If you have asplenia, these are the guys you worry about, and the mnemonic is BEDS. Babesiosis, encapsulated organisms, DF2, which is capnocytophagic catamorphosis, S, which is salmonella. If you have liver failure, cirrhosis, LIVA, L, listeria, Y, Yersinia, B, Vibrio, okay, and then that's Vibrio non-cholera, and then A is Aeromonas, which Aeromonas is the freshwater version of Vibrio. So it's like, it's like having a cousin that's just as evil as you. So Aeromonas, and it's got a other cousin known as Plesiomonas. So Plesiomonas, Plesiomonas, is the same thing as Aeromonas on the boards. It's a freshwater organism that likes to cause a very aggressive cellulitis that can even be bullous and hemorrhagic. And the treatment for Aeromonas, Plesiomonas is penicillin. That's why they love asking it. Anytime the answer is IV penicillin, they're like, I got this resident. They'll never answer IV penicillin. They always will choose piperacillin tazobactam or something really big. So it's like there's a little fly there, and I could go like this, or go like that, or jump on it. So they're always going to bank on the resident either going like this or jumping on it rather than going like this. So, all right. the last one I wanted to get to was the endocarditis stuff. I think all this stuff is better for you to read, I think. GU, and I like to call these the under the belt infections. So young college age females, staph saprophyticus. Nobody thinks about this bug. Hell, I haven't seen one of these since 1996. Yeah, I bet you if you take your boards and they tell you that in the urine there's a gram-positive organism, and in the blood there's a gram-positive organism, and they go out of their way to tell you this is not an IV drug user, there's no murmur, this gal does not have endocarditis. They want you to know that Staphylococcus saprophyticus is the organism involved, even though you're never going to see it. Stupid. All right, and remember, asymptomatic bacteriuria in pregnant patients equals treatment. What's the other thing that equals treatment for asymptomatic bacteriuria? We just did it in ID board review this week at the VA. Exactly, GU procedure. If you're going to go for a GU procedure, you need treatment for asymptomatic bacteriuria. And the other condition is if you're pregnant, and that's it. All right, here's a picture of emphysematous emphysematous cholecystitis. That's the actual gallbladder in a patient of mine way back when. I think that was 2001. It also has some pretty cool stuff. There's also a sentinel loop of small bowel, and an ileus on it. All right, this is the last slide we're going to do for ID before we go on break. So this is the painless ulcers and the painful ulcers of GU. So similar to in the oral cavity, it's easy. In the oral cavity, if you have a painless ulcer, it's lupus. If you have a painful ulcer, it's Behçet's. That's really the only one you got to know. And then obviously anything that else is, if you have a herpes infection in the mouth, is going to be painful. And there's other variants, immunological variants, that you can get ulcers, and they tend to be painful. But Behçet's tends to be like aphthostomatitis, is painful. But Behçet's is the only painless oral ulcer state. Now, when we're talking about GU ulcers, painless, the syphilis chancre, painless. The lymphogranuloma venereum, which is, of course, caused by the serovars of chlamydia trachomatis, which is treated with tetracycline or doxy first, then Septra, that's painless. LGV is painless. Granuloma inguinale, which is caused by Chlamytobacterium granulomatis. Why am I taking my time with this? Because you guys don't, this is your chance, this slide is a don't forget slide. Because you don't see a lot of these under the belt infections unless you do HIV, public health with Dr. Cho or with Dr. Morano. But this will get you every question you need to get right on the boards for GU ulcer. Also known as Donovan bodies. So Donovan bodies goes with granuloma inguinale, which is Bacterium granulomatis, treated with tetracycline or Septra. So very similar to lymphatic granuloma venereum. Isn't that great? Even if you screw up which one's which, you're getting the answer right, as long as you go with doxy, first line, Septra, second line. Now, look at the helpful thing. So usually no lymphadenopathy with granuloma inguinale, whereas I didn't write it here, but lymphogranuloma venereum usually does have lymphadenopathy. And that's helpful because it starts with an L. So lymphogranuloma starts with an L, so lymphadenopathy. No lymphadenopathy usually with granuloma inguinale. And then these are also painless, which are the condyloma acuminata, HPV, that's also painless. All right, now we go to painful. Chancroid, also known as Haemophilus ducreae, or as I like to say, do cry. All right, you will cry because it's painful. All right, gram-negative looks like a railroad track. So this one looks like Donovan bodies, granuloma inguinale. Chancroid looks like a railroad track, gram-negative. Notice the treatment changes. For chancroid, if they're crying, don't give them doxy. Don't cry for me, doxy. If they're crying, give them macrolide. All right? And even macrocrylide. There we go, Dr. Evil. So from Austin Powers. All right. No one likes that. Matt Wilson's like, no. Septra or fluoroquinolone. And usually you do have lymphadenopathy with chancroid, and it's painful. And then HSV is obviously very painful, as opposed to HPV, which is not painful. HSV is painful. I know when you see somebody's cauliflower mass coming out of the ass of somebody, you must be going, man, that must hurt. But it doesn't hurt. So, all right. But it looks like it would hurt. So, all right. Anyway, so that's the big slide in ID. And then the rest here, I have for you, for your viewing at home, several great infectious disease pearls that I liked. I would say this wraps up as my top 20. A lot of this emphasizes something, although I need help from the med peds people because this is on your boards. Metronidazole is a first-line treatment of Giardia lamblia. Quick question. What is the most common immunodeficiency that you will see Giardia lamblia associated with? IgA, right. Selective IgA deficiency, even more common than common variable immunodeficiency. Very good. Now, the other drug is Alinea that's used for Giardia lamblia. I always struggle with how to say that damn drug. Nitoxazonamide or Maper. How do I say Alinea? Maper's like, I have no idea. So, Megan, how do I say Alinea? Like the what? Alinea. I love that. Say it clearly, Lezama. So, anyway, it's like nitoxazonamide. So, that's the generic for Alinea. Sometimes they won't put metronidazole on the boards for Giardia, even in adults. They'll put the kid drug on there, which is, again, I think it's nitozonamide. So I wanted just to give you a beware on Giardia, because that's come up a couple of times over the years. What I do, which I can't take from the residents over 19 years, they come to me and they talk about table of contents stuff. They don't tell me the exact question, or if they do, I go, la, 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 la. But they tell me about table of contents stuff and where I'm right on the money and where it was kind of almost there. And then I change what I teach every year based on that feedback. And what I tell you is the test hasn't really changed that much in 19 years. And they like the esoteric second line agents so much. It's unbelievable. All right, so anyway, those top 20 pearls are there for you to view, and some of them do emphasize stuff I already went over. Some of you may have never used Astrinam, for instance, in number 9, and go, Astrinam, or when the ER gives it, you go, what is that drug they're giving? Which I will soon discontinue. Because, Astrinam has got pure gram-negative aerobic coverage, and it's basically useless this day and age. It's a historical type thing. It's great for board questions. But you're only going to use Astrinam for like a E. coli gram-negative infection, a pure aerobic infection. Anything anaerobic or gram-positive, Astrinam will not work. And really doesn't have to be used now that we know that first and second generation cephalosporins are safe in people who have penicillin allergies. All right, let's take a break for how about 10 minutes? Time, Harold Paul, is 3:40. It's not 3:40. So... What time is it, Paul? 10:12. Let's pick it up at 10:25. Take 13 minutes to bathroom. Harold just wants to go running on Bayshore. So, Harold, not yet. All right, go 10:25. We'll pick it up again. Now I have to say, en panopto. Panopto, I would like to stop.